Good morning everyone, and thank you for joining this webinar. My name is Mandy Luckman. I'm a partner at Irwin Mitchell and I'll be hosting the event today. Cancer Research UK has estimated that around 3 million people in the UK have missed out on cancer screening since the end of March. More than 350,000 people who would normally be urgently referred to hospital with suspected cancer symptoms weren't. The charity fears that up to 35,000 extra deaths may be caused by cancer because hospitals were advised to cancel all procedures, including checkups and operations to cope with the COVID crisis when it struck. Estimates suggest that during lockdown, 13,000 fewer cancer patients had surgery, 6,000 fewer underwent chemotherapy, and 3,000 fewer had radiotherapy. In some cases, people died because of delays to surgery or care, whilst others have been left with a much poorer prognosis. I'm sure that we would all agree that this data is extremely alarming, and so today, I'm privileged to be joined by 3 eminent speakers, all of whom have a wealth of knowledge about cancer from different perspectives. We're going to talk about cancer services during COVID-19 and hope to arm patients with knowledge that enables them to make informed decisions for themselves. Please do send your questions through and we will do our very best to answer as many as possible. If we're unable to get through all of them, then we will endeavour to address them following the webinar. So please, when submitting your question, please do remember to include your name and your email address. So I'd now like to introduce our 3 speakers. We have Professor Karol Sikora, who is Chief Medical Officer of Rutherford Health. He was the founder of Cancer Partners UK, which has created the UK's largest independent UK cancer network with private equity. He was Professor and Chairman of the Department of Cancer Medicine at Imperial College School of Medicine and is still Honorary Consultant Oncologist at Hammersmith Hospital in London. He was seconded to be the Director of the WHO Cancer Programme in 2000. He was the founding Dean and now Professor of Medicine of Britain's first independent medical school at the University of Buckingham and a Fellow of Corpus Christi College in Cambridge. He's published over 300 papers and written or edited 20 books, including Treatment of Cancer. His book, The Streetwise Patient's Guide to Surviving Cancer, was published recently. 3 months ago, he joined Twitter and has already over 300,000 followers. And during the COVID crisis, he's been dubbed by the media as Positive Professor. Bob was diagnosed with malignant pleural mesothelioma in the summer of 2019. His first treatment involved being part of a clinical trial and certainly helped his condition. He is currently on second-line treatment using immunotherapy. His first scan on this new treatment is due in December and his fingers are crossed for a halt to the progression of his cancer. Bob has an eclectic career working in hospitality, wheeler dealing in the antiques trade and managing tourist attractions. For the last 20 years, he has worked as a full-time professional magician and entertainer. He's been actively involved in the magic world, travelling and working all around the country, and is a member of the Magic Circle. Away from work, Bob is a keen sailor and has raced across the Atlantic Ocean. He also holds a private pilot's licence and he tries to keep himself fit and healthy, even more so since he was diagnosed, and gets out on his new electric bike as often as he can. Michaela is an occupational therapist. She's worked in a variety of physical and mental health settings in the community, hospitals and in hospices. As a specialist palliative care OT, Michaela has supported people with life-limiting illnesses, neurological and heart conditions as well as cancer. She's provided assessment and treatment with a cognitive behavioural therapy approach for people with anxiety and depressive disorders. As a client liaison manager at Irwin Mitchell, she continues supporting individuals to manage their rehabilitation and reduce the impact of change whether it be as a result of physical illness, traumatic injury, or mental health difficulties. So I'm sure you'll agree we have an impressive panel of speakers with us today, and perhaps Professor Sikora, we can start with you. What are the warning signs of cancer, and if a patient is concerned or worried about symptoms that they may have, what should they be doing?
So thanks very much for inviting me to this. It's very topical. I mean, the problem we've got is that every day 1,000 people present with cancer. That means they get cancer-like symptoms and they will be diagnosed as having cancer. What's happened over the last 6 months, in the first 3 months, that was April, May and June, the numbers of people with cancer dropped off drastically to about 20% of what it should be. It's picked up now, but we're still not at 100%, which means there are people out there that must have symptoms that are not being sorted out. And that is a disaster. That is the current problem at the moment. Now, depending where this all goes, you know, I've tried to be positive throughout, but at the moment I'm sitting here in my office in Marylebone in central London, and you know, just reading that London's going into a sort of gentlemanly lockdown in a couple of days' time. Different lockdown means different things to different people. In this country, it doesn't actually mean that much. In other countries, Latin America, France, it means a lot. And I think, sorry about that, what we're going to see with lockdown here is that culture of fear of not using NHS facilities for cancer patients. What we've seen over the last 6 months, and the reason that we've dropped from 1,000 patients a day to around now about 600 are coming through a day. Where are the missing 400? Well, there are 3 reasons why they're not there. Number one is the patients and their families. They're too frightened to actually do anything about it. They don't even want to call the GP. They'd rather put up with the symptoms, and I'll come back to those in a minute, Mandy. The second is the whole primary secondary care interface is not working as well as it could be. Difficult to get an appointment to see your GP. It's often down the line, and down the line appointments are not so good. Are not so good because you can't get the subtlety of the interaction, the patient and the doctor, and obviously you can't examine someone down the line. And the third problem is within the hospital. Certain investigations that may be very necessary for cancer, such as colonoscopy, where you put a tube into the colon to have a look round for colon cancer, generates aerosol. It's inevitable. So aerosol generating procedures are the bane of hospitals at the moment because they require extra precautions. So in the good old days of February of this year, an endoscopy clinic where you put many tubes up people to see what's going on, you could do maybe 15, maybe 20 patients in a morning. Now you can only do 3 or 4. So inevitably there's a waiting list, which is growing every week more and more. So these are the 3 problems we've got to overcome. Why does it matter? Well, I guess it matters because any delay with cancer makes treatment more complex and outcomes worse. So if we actually look at something like breast cancer, and there's good data, you can find it on Cancer Research UK website, looking at the outlook for different stages of breast cancer. If a tumor is confined to the breast, the outcome is really excellent now. About 98% of women will survive 5 years, and most will survive forever. Most are cured with stage 1 disease confined to the breast, small tumors in the breast. Stage 2 involves the lymph nodes around the breast, usually in the armpit, but there are other lymph nodes in the chest that the breast cancer can invade. There, the outcome drops, but not too badly. It drops to about 85% with optimal care. Then, if you wait a bit longer, the cancer spreads to other areas of the body. Within the lymphatic system to start with, that's stage 3 breast cancer, and then outside the lymphatic system to the liver, to the brain, to the lung, which is stage 4 cancer. The prognosis of stage 3 is less than 20%. So you move within a few months from stage 2 at 85% to stage 3 at around 20%. And the treatment is much more complex: chemotherapy, radiotherapy, other treatments, hormonal treatments, and so on, antibody treatment with Herceptin. So the list goes on. So getting cancer early is really important for some patients. And a very interesting study from a group of physicians at University College that came out in mid-July tried to estimate the differences in different delays caused by COVID, 1 month, 2 months, up to 6 months for different cancers. And the effect is different on different cancers because of the way it spreads, the natural history. Of course, we won't really know how damaging the pandemic to cancer patients until we can look at all the data in about 2 to 3 years' time. We don't know who it is that's actually suffered from this in terms of delayed diagnosis. We just have to wait to see what happens. And even then, individuals won't be identified. It'll be very much, well, the cancer survival for 2020 has dropped by, I would estimate, around 20%, that sort of thing, at the way we're going. Now, amid all this gloom and depression, it's been recognized that cancer patients need some better prioritization, and the NHS service departments, radiotherapy, chemotherapy, and the diagnostic departments are doing their best to try and catch up. The real problem with cancer is that the symptoms of cancer are usually not due to cancer, they're due to something else. If you look at breast cancer, 1 in 10 women that have a lump in the breast have cancer. The other 9 are fine. If you look at colon, irritable bowel syndrome, for example, impossible to differentiate without putting a tube in the orifice into the anus or doing a CT scan of or ultrasound of the abdomen. So you've got to do the investigation to separate the cancer patients from those that have benign disease which will right itself. And if you want the symptoms of cancer, there's really nothing specific, but starting from the top, any headache that's unexplained, any sore throat, any cough, coughing up blood, abdominal pain, unexplained weight loss, difficulty passing urine, blood in the urine, pain in the pelvis, change in periods, vaginal bleeding, any swelling anywhere in the body, lymph nodes or lumps anywhere. These are all potential signs of cancer, but in most cases, they're completely innocent, and a visit to the GP can reassure people, but sometimes it can't. Different cancers present in different ways. So where's it all going to go now? So looking at yesterday's data for COVID, there were something like 655 admissions to hospital. That's the key number. Everything else is sort of not relevant to seeing where this is going. The curve of admissions is going up, but it's totally different from the curve that was there in April, where it was shooting up. And April the 8th was the worst day in the NHS ever. And I've been a consultant for 40 years, so I've never seen anything like it. The number of admissions were just shooting up. We're not seeing that now. It's a much more slow increase. And it does look to me, but then I'm trying to be positive here, that it's plateauing off. As we go every day, the data are printed on the government website. You can see for yourselves where it's going to. That is the key figure. If that continues to go up, cancer services will suffer, because it means switching what's going on in the hospital away from the routine, which includes cancer, to COVID. If it doesn't go up, and it's not going up in London at the moment, it is going up in Liverpool. If it doesn't go up, then cancer services can be maintained. But there's innovative ways of maintaining cancer service and whatever's going on around. And indeed, you know, radiotherapy and chemotherapy has been delivered consistently. So how we actually get the diagnosis done, the investigations, the scans, the endoscopy, these are the key features for the next few months to keep going in the face of winter pressures, in the face of increased COVID activity and so on. But going back to the beginning, it's clear that the problem with lockdown is fear, and it makes people tend to ignore symptoms. You know, the most surprising observation in the last 6 months is that for 3 months, the incidence of heart attacks dropped to 45% of what they should have been. And it's not that they really dropped. People were having heart attacks. They just weren't going to hospital with them. They were staying in bed, staying at home with chest pain, taking painkillers, taking trinitrin and hoping it would go away. A lot of them could have been stented. They haven't been. And that was going to bring long-term problems for many, because it's going to mean that more of the heart muscle has been irreversibly damaged because of the delay in action. And that will lead to cardiac failure, heart failure later on, maybe a year, maybe 5 years down the line, and it'll shorten their lives. So there's no doubt having a much more balanced approach to cancer, to heart disease, to stroke is clearly important as we go forward. And you know, that's why I did my Twitter. And has it fallen on deaf ears? No. I mean, Hancock today has talked about doing something about cancer. The difficulty is what and how, and what happens in a culture of fear with a health system that is really operating in a very different mode than it was this time last year. So let me stop there and hand over back to Mandy. Thank you.
Thank you, Professor Sikora. That's really valuable information, very interesting to hear. Before we move on to Bob, I just have one question, which is, from what you said, it's very clear that time is of the essence here, and it sounds as though clinicians are doing their very best as well to ensure that patients can be seen if they need to be seen. But if patients are concerned about particular symptoms and they're in difficulty securing a face-to-face appointment with their GP, for example, is there anything that they can do? Is there anything that they should be doing to try and address that?
I think the most important thing is persistence, and it's sometimes difficult for older people, because I mean, people my age, I'm an older person, and there's no doubt it's difficult because in the past they didn't have to. They'd go down the GP surgery, they'd make an appointment with a friendly receptionist, they'd be seen by the same doctor. That was how medicine was. Not so long ago, we've forgotten those days. And if they did get problems in the evening or at night, the GP would still do home visiting, and it'd be someone they knew from the practice. That's all gone. It's now phones, and it's with people you don't know, and that is very difficult. It's not so bad if it's face-to-face with people you don't know, but if it's on the phone, it's difficult, especially if they're curt and in a hurry, and that, unfortunately, is some of the attitudes in general practice that we see. So if we could the most important thing, Mandy, is that if people have a symptom that's persisting. You know, if you have a headache for a day, that's not a problem. But if it goes on for 2 weeks, 3 weeks, and you can't get rid of it, and it's getting worse, persistence and progression are the two things about cancer. If things persist and get worse, then keep making a call to get to see to get to at least speak to your GP. Don't be put off if you can't go and see them, but at least speak to them, and at least, and just go back. If the symptoms persist, just go back. There's some fascinating studies in the last 5 years looking at GP diagnosis of cancer, and for some cancers, a single visit does the trick. And that breast cancer, you have a lady has a lump. That lump is there, the GP feels it, refers the patient to the breast clinic. That's fairly straightforward. Pancreatic cancer, on average, 4 visits to get that sorted out. Vague abdominal pain, maybe a bit of weight loss, a bit of sickness, of indigestion, gets put on drugs to reduce the acid production in the stomach, and patient goes back, and it may take 6 months sometimes before the true diagnosis is made. And the characteristics of people that have a slow diagnosis are those that don't persist. So I think persistent in a nice way, not in an aggressive way. Don't shout at the receptionist, she's doing her job. Don't shout at the GP, but certainly persistence is really important. And the early diagnosis of cancer is just the most important single thing we can do. the reason we're behind Europe in overall survival is not because there's no cancer treatment is not so good over here. It's perfectly good, and all my colleagues are perfectly good oncologists. The problem is the whole diagnostic pathway is slow. In France, even now, even with all their problems with COVID, you will start treatment within 10 days. Here, the target is 62 days, which is hopeless, and patients miss their target even at 62 days. So speeding up that whole diagnostic process, beginning with the patient being persistent, and if it's someone you care for, then and they don't really feel too good, and they're not up to persist for them. It's often easier to fight on behalf of someone than to fight on behalf of yourself within the system. And don't be put off by the dire messages, save the NHS, protect the NHS. The NHS is there for you. And I think I'm optimistic that there'll be some decent messages about cancer coming in the next few weeks.
Thank you, that's really helpful. Very interesting to hear. So perhaps we can now move on to Bob, who, as a patient that has accessed cancer services during COVID, is in a position to let us all know what his experience has been. Bob, would you be able to take us through that, please?
I apologise, I hit the wrong button. But yeah, and thank you very much for inviting me to this webinar. As you said, I was diagnosed with mesothelioma in the summer of 2019, and I thought I'd just go over what my feelings were at the time, and well, it was a sort of feeling of blackness, really. There was no good news. I felt everything was going south. I was diagnosed with a terminal illness. I had a good friend that had the same illness who died 5 days before my symptoms first started. So I was looking for hope, and all I could find was despair, because with mesothelioma, the life expectancy was pretty grim. The type of mesothelioma I had was made things a little bit tougher, and I had continued progression of the cancer. I was rejected for a clinical trial for good reasons, and so nothing looked really particularly rosy. But then some hope did come, really, because once I was rejected from the trial, I was admitted very quickly for another clinical trial, which was the atomic trial, and that started within a couple of weeks of my meeting with a consultant. It involved 18 weeks of chemotherapy, which came every 3 weeks, and then once a week I had a jab of a sort of the trial drug or a placebo in the bum, which wasn't that unpleasant. I went to Leeds, to the Leeds Clinical Research Facility for all of my treatment, and it was really good. I mean, it seems mad to say, but I really enjoyed going and having my treatment. I met new sort of cancer buddies, and even though everyone had sort of quite poor prognosis, it was they were a jolly, cheery and helpful bunch. The nursing staff were good fun. They looked after me well, and so I continued with my treatment. I even managed to do a magic show for everyone at Christmas, which was not easy when you've got a cannula and you're being sort of stuffed up with chemotherapy. The first scan was the first CT scan I had after the treatment showed that there was no progression, and in some areas the tumours had thinned a little. Well, when my consultant, Dr. Franks, told me, I could have jumped up and hugged him, but I didn't think he was the hugger type, but I might be wrong. There was so that was all good. I also joined a mesothelioma support group called MESI, which was in Yorkshire, and that was run by my lung cancer nurse, Simon Bolton, and that has been really inspirational for me, because there are people that are outliving their life expectancy rates and all that sort of stuff. And again, we have good fun, and it's a laugh. And then this thing that I'd never heard of before, called coronavirus, rocked up. Now, my consultant, Dr. Frank, explained very clearly the risks of turning up at a hospital while this virus was going. But there was also uncertainty with a clinical trial as to whether it could be paused or not, because the general rule, I think, was if you missed 3 consecutive sessions, you were booted off the trial. So basically, it was my call whether I wanted to continue or not. Weighing up all the options, I decided to continue. So something that I was having that was doing me good, and I didn't really want to jeopardise that. So I continued. Treatment was a bit different during lockdown. I wasn't allowed to wander around and talk to my cancer mates. In fact, I got told off several times for doing that, and they made sure. They said, "Right, Bob, go and sit down. You're not supposed to be walking around." The hospital was definitely like a ghost ship. It wasn't, the busy hub that it was before. But the big bonus was how easy it was to drive there, and how quiet the roads were, and how easy it was to find a parking place in the hospital. En route, I got stopped a couple of times by the police, asked me where I was going, and on the second time I was a bit mischievous, and I told him that I had terminal cancer and I had to get to hospital quickly for treatment. It was all very embarrassing, because at one stage I thought he was going to blue light me there. And I suppose the worst thing for me was that they closed the cafe in the hospital, so I couldn't have lunch after my treatment. So I continued through lockdown, having treatment through lockdown, until I was booted off the trial due to a suspected allergic reaction. At the time of lockdown, for mesothelioma, there was really only one treatment on the NHS, and that was chemotherapy. But many meso patients opt for clinical trials because there could be a better outcome. Unfortunately, during lockdown, those trials stopped completely, which was a real blow for lots of people, because the one thing mesothelioma patients, and also, well, all cancer patients don't have on their side is time. And so there was, quite a few friends of mine that weren't able to get on to trials that they'd hoped to get onto, because the door had been shut during lockdown. Getting through COVID has not been too bad, really. I've had loads of support from friends and family, lots of contact via Zoom and FaceTime, and other video platforms are available. Getting out walking the dog. In Harrogate, they have, which is my local hospital, they have this great organisation called Active Against Cancer, and they do all sorts of exercise groups for old fogies like me. That closed for a while during lockdown, but then it reopened with walks, and at the moment it's sort of fully open again. Nicola Handley, my great solicitor from Irwin Mitchell's, she said I should go out and buy myself an electric bike, and so I did, and I've made lots of use of that. And at the moment, I'm on a second line treatment. I'm having immunotherapy, but I'm feeling good, feeling fit and well, and long may it continue. Thank you.
Thank you, Bob, for sharing that personal experience, and I'm pleased to hear that it's largely been a very positive one for you. I'm conscious that it sounds as though you've got good communication with your clinical team prior to COVID, so that when it struck and they picked up the phone to talk to you about your options, you were able to have that dialogue and ensure that the questions that you had were addressed. How important do you think that those communication channels are, and do you have any feedback perhaps from others on your support group about different experiences, and what should they do about that?
Well, I think that communication is absolutely vital, and speaking to my mesothelioma friends, you know, it seems that is not always the case, and you know, different consultants, different NHS trusts work in a different way, and so not everyone, I don't think, has got the level of communication that I've had, and the straight talking that I've had. So that's a shame.
Okay, thank you very much, Bob. So we'll move on to Michaela now. Really interested to hear your views on this topic. If someone has been affected by cancer, what support is out there, Michaela?
I think firstly, I'd just like to say, you know, great to be here with all of you. And I think two things that both Professor Sikora and Bob talked about was the importance of communication and raising, you know, the difficulties or symptoms you're having. And the other thing, that culture of fear, because I think that is such an underlying theme for everyone, those affected by cancer, but for all of us. And I think there's that culture, you know, in the NHS, but also in community services, in fear around going to the doctor, and all of that. And I think this picture and this quote I was given very early in lockdown, and it keeps being useful in the sense of, you know, we're all in that storm, but actually we're all in very different situations. And sometimes it's really hard to access that support. And I would absolutely agree with Bob that there is such variety. I have some clients and friends and family that I know of who are living with cancer who have excellent support, you know, really easy access to GP, to specialist nurse, to local cancer support groups, and others who are finding it very, very difficult. And sadly, some of those have been palliative care situations where people have literally died at home without that support. So it's hugely variable. And I think I'd so agree with Karol, that whole sense of being persistent, that actually the NHS has not shut down. The NHS is obviously under huge strain, but it is open for business. It's just business in a very different way, or that very hackneyed phrase now, the new normal. And I think it's about recognizing that we may not have got the support in the way that we're used to, but we still need to persist, or we need to find other ways. And that's very hard, because so often, I mean, obviously, Bob, you're a very informed patient. You've got your messy group, you've got your specialist nurse, you've got your consultant. If you're in the early days of a diagnosis or pre-diagnosis, you don't know where to go for help. The other thing that Bob and I were talking about before we started was that for people who are in remission, so maybe, for example, they've had treatment, they're in remission, their cancer's at bay, but they're very heavily shielded, that can feel like a very vulnerable time, because you've gone from the project, if you like, of your cancer treatment, you're in and out of hospital, you're having blood tests, you're maybe having support with your site-specific cancer, like Breast Cancer UK or whatever, and then suddenly it goes quiet. And the enormity of the losses of maybe not being able to work, not being able to see family and friends because of being immunocompromised, being shielded, all of those things have sort of added to that sense of threat that I think we're all feeling. But I think if you're living with cancer, and for many people who are obviously living with bereavement related to cancer, that's at an even higher level. And I think for so many of us, that's so important that actually we try and manage that sense of fear and threat, and deal with the unknowns. We're all dealing with unknowns. How long is this going to go on for? When will I be able to see my GP face to face? When can I see my granddaughter? When can I get my hair cut? Whatever it is. But that actually, you know, the way we deal with those unknowns really make a difference to our everyday. And I think, Bob, you're a great example of actually keeping on contact with friends, taking the dog for a walk, getting an electric bike, you know, actually saying, well, I need to do things differently, but I still need those things, those connections, that contact with my consultant, the fresh air, etc. So it's really important that people look at their own situation and say, right, I'm having to do it differently. What can I do that's helpful? And what do I do that's unhelpful? I know for myself, I'm doing some things that are really helpful. So regular connection with friends and colleagues. And I'm doing other things that are unhelpful. So I think, oh, I can't be bothered to get out to have some exercise, or it's getting dark in the evenings and we become a bit hermit-like. So it's recognizing what your coping skills are and, you know, tapping into those in the best way possible.
Thank you, Kate. That's really informative. So I guess it's clear from what's been said so far that patients going through this experience are going to have good days and they're going to have bad days. And what are your top tips for getting through these? Would they be going to professional support organisations, or are there ways that you can manage that at home?
I think there's a variety of things. If you could move on to the next slide, please, Becky. Thank you. I think with that sense of threat that I explained, and I think as Karol put it, the culture of fear that we're all in, we're in that part of our brain that is looking for danger, is responding to worrying thoughts. And if we live at that pitch all the time, it's exhausting. And obviously, if you've got a cancer diagnosis on top and you're living with fatigue or nausea or pain or restlessness, you've got, you know, accessing that sort of threat system all the time is exhausting and is not good for us. So I'd say one thing we really need to do, is something we can do without professional help, is access what we call our rest and digest system. So the sort of restorative parts of our brains, rather than the alert, danger, you know, sort of meerkat looking over the cliff type part of our brain, more the soothing system, the restorative system. And we can do that by doing other things. So switching our brain to something else. If I realize I'm getting in a bit of a worry cycle, I'm like a hamster in a wheel, I can do that by changing what I'm doing, getting out, getting fresh air. And if those things are harder for you because you're shielding or because you're physically not so able, one of the easiest things to do is some deep breathing. Because when we're in that sort of threat system, what we tend to do is breathe in a more shallow way. That builds up, and that can lead to much higher anxiety, or even to things like panic attacks. So actually we can learn to do deep breathing, and I've put a link on the resources page, Mandy, so that people, if they don't know the technique, really easy to learn, free of charge. You don't even need an electric bike to do it. Really useful thing to do. We can do it, you know, between phone calls, before a meal, while we're cleaning our teeth, while we're boiling the kettle. Really useful, so that we're accessing that different part of the brain. We can't do the both at the same time. The other thing I think is a really simple thing, but is when we can hear ourselves, because naming our anxiety is really important. We recognize it, is thinking, is this helpful? Is this worrying about what's going to happen next week, the week after, helpful? The answer is no. We all do it. But in the time of fear, in the time of depleted energy, we're wasting energy. So really asking ourselves, is this helpful? If it's not, I'm going to do something else. Obviously, I would recommend that if people's anxiety or low mood, or if they have thoughts of harming themselves because they're feeling so distressed, it is really important that people do seek professional help. There is obviously in the news a lot of talk about the huge rise in people's mental health difficulties. And it's so important, as you know, we all probably read and heard about on World Mental Health Day at the weekend. Important to talk, important to connect with the GP, access mind, access help where we need it. It's very easy in this situation to think, well, everyone else is struggling, so I've just got to get on with it. But if we are really struggling, it's a degree where we feel we're losing control, or we're frightened, so frightened that we feel, you know, maybe harming ourselves, or worse, is a solution. We really do need to get help through our GP. There is the Samaritans, and obviously there are many mental health charities that provide that support. And I think, you know, it's also recognising that we're all having good and bad days. Some days where we just can't be bothered, we want to hide under the duvet, we can't face it all. And other days where I think, actually, I don't really feel like it, but I'll make myself go for a walk, and just turning the tide of that day. But the other thing I think, and I think, is to be very mindful of social media, the news, etc. It's very easy, and I've done it myself, where we overlook at the news, we overlook at social media, and that can just escalate our anxiety, and it doesn't give our brains a break. We need to give ourselves a sort of a break from that fear, and you know, that's really, really important.
Thank you, Michaela. That all sounds very sensible, some really helpful tips there. We are starting to get some questions come through, so perhaps we can address some of those now. And the first of which I'll direct to Professor Sikora, which is in respect of patients attending hospital outpatients but non-urgent interventions or investigations when they're living in a tier 3 area. Should their process for deciding whether or not to attend those appointments, if they're not urgent interventions, still be the same if they live in tier 3 or tier 1?
My advice would be to carry on, as long as they don't have one of the 3 coronavirus symptoms: loss of taste or smell, temperature, dry cough. As long as you're well, then go along. If there's a problem in the hospital, they'll cancel it anyway. So, but some of the tests are important. It depends at what point. Certainly, if it's a diagnostic test because of symptoms, that is to look for cancer, that's really important. If it's something like a PSA test, a blood test for prostate cancer, it's just part of a yearly follow-up, and you want to delay that by 3 months and you've been fine for the last few years, that's not so important. And if you really feel like delaying it, just do so. But if someone with new symptoms, they should definitely go along. And even for follow-up, my advice would be to carry on unless you're told not to, because they can't do it, and as long as you have no symptoms.
Thank you. And a question for Bob, if I may. We obviously have talked about the impact on patients whilst they're going through treatment for cancer. Are there any observations or thoughts that you have about the effect on patients once that treatment is over?
Sorry, could you say that last bit again, please?
So we've obviously talked quite a bit about the effect on patients whilst they're going through cancer treatments. Do you have any thoughts on effects on patients after they've finished that cancer treatment?
Well, I think when you finish your treatment, even if you're totally in remission or cured, if that's the right term, then I think you can be down in the dumps, and you still need that good contact. You know, my sister-in-law had breast cancer, and she had fantastic treatment, and she's still in remission now. But once the treatment stopped, she felt alone, really, and got really quite down about the whole thing. So I think that's something that you know, people need to look out for. That once you stop having that treatment, your mood can go down, and you can possibly have dark thoughts and get a bit miserable about it all.
And another question for Bob, if I may. When you went into hospital for treatment, how did you feel? Did you feel safe? Did you feel that there were different precautions that they were taking because of COVID?
Yeah, I didn't have any anxiety about it at all. I thought they appeared to have it all under control. I mean, I wouldn't know. Karol would be the best one to answer that, really. But no, I felt very happy with how they were doing everything, what precautions they were taking, and I would rather be there having the treatment than staying at home and not having the treatment.
Absolutely. And Michaela, do you have any thoughts on that, please?
Yes, I think, Bob, I think that's absolutely right, that, you know, to go ahead and to be there. But I would say a lot of people that I'm speaking to are really struggling with the anxiety of what happens if, will there be space? Will everyone be social distance? Will there be cleaning facilities? Will I be able to get a cup of coffee? What if there's people I have to share the transport with? So I think a lot of people are not feeling as confident. And I think obviously if you've got a cancer that's lung related and you're already struggling with your breathing, if you've then got heightened anxiety, that will affect your breathing, and then you're having to wear a mask on top. So I think, you know, for a lot of people, they are really anxious about it. And I think, you know, don't be frightened, again, be persistent to ask what are the precautions, or what can I expect, or will I be able to, you know, so rather than being at home, building up that fear and anxiety about going for treatment or going for a consultation, ask those questions, ask for an email and write, if you're, you know, you need to write a list of, you know, or can I bring someone with me? There's also a lot of people's fear that they'll be waiting for long periods on their own. They can't take someone with them. That's not the case. But again, if those are fears, it's better to ask the question and get some reassurance and have a familiarity. I know some centres are doing, you know, they've got a sort of an online video or guidance about what to expect, because as Bob said earlier, you know, hospitals do feel like ghost towns in a way, and all the normal facilities or the normal way of doing it might be different. So ask those questions before you go, but don't let it stop you going.
Thank you, Michaela. And I guess just on that topic, Professor Sikora, are you aware of the additional precautions that hospitals, clinicians are putting in place just to make this as safe as they possibly can?
Yeah, I think that the difficulty is that what we tend to do in oncology is assess the benefits and risks to an individual of a potential visit for chemotherapy or for radiotherapy. Radiotherapy is fairly straightforward. Chemotherapy is a bit more complex because the value of different regimens in different situations varies enormously. And if you take something like breast or colon cancer, where we give a lot of adjuvant chemotherapy, that's chemotherapy that's given to reduce the risk of future recurrence. There's nothing to measure. We don't know if it's working or not. You have to give the full 6 cycles if the patient will tolerate that. And that's tricky because, you know, for relatively small gain with chemotherapy, you're putting that patient at risk from infection and so on. And not just by coming to the hospital, but by all the bits in between, public transport if necessary, and so on. So it strikes me that we panic a lot about you know, social distancing and washing hands and masks and so on. But you know, I'm sitting in an empty London more or less, and there's no doubt the biggest risk is public transport, where you're stuck on a tube together. I mean, a tube in a sense, a bus tube or a plane or an underground or a train. And that's the biggest risk for our cancer patients, probably. So getting them brought by someone that is in their family is clearly the best way. And as Bob said, the cancer service departments are on the whole much lighter at the moment. In fact, some are pretty deserted. I was at the Marsden yesterday morning, and it is pretty deserted there. because all the normal outpatients that fill the car parks and come to the clinics don't come. They're dealt with on the phone or by Skype. So there are some benefits from all this, and some of the changes are going to be here forever. So Skype consultations, telephone conversations rather than clinic, that's going to be here even when this virus disappears, and hopefully it'll be soon. And but that sort of thing, it for many people it's just great. If you're busy and you have prostate cancer, to use that example again, I would see about 20 men in the morning in the prostate clinic at Hammersmith in the good old days. A few phone calls and blood tests from your GP, no need to come into town, fantastic for most people. If there is a problem, then they can come, and that allows you to concentrate on the people that really need the attention, I guess. So I think there are things that will come out of this that will change healthcare forever. And just like we're having this conversation now, we'd never have done this a year ago. We wouldn't have done it on Teams. I never heard of Teams a year ago. So there you go. I've never heard of Zoom. You're younger, Mandy, so you have. But, you know, I never use these things. Now, I'm not exactly a dab hand, but I can connect, you know, which means I've improved.
Thank you very much. Yes, we've all acquired a lot of tech knowledge since this experience has hit. And perhaps then, I'm conscious that we're approaching the end of the webinar today, but Michaela, do you have some further thoughts that you'd like to share with us?
Yes, thank you, Mandy. Yes, thank you, Mandy. I mean, obviously echoing what Bob and Sikora and yourself have said, is that it's really important that you do access that support. And we've got a slide on the screen there that just reminds you of the support that is there. And I've noticed that many of the cancer websites with support are also having specific COVID guidelines. So if you have got concerns about going to treatment or accessing your GP, you know, they've got some really good information and some guidance for you. So do access those. The other, which is a bit of a personal plug, is for the Maggie Centres. We're lucky to have 25 Maggie Centres in the UK, and they can feel like really safe havens because they're in the hospital grounds, but they're kind of not so clinical. And if you've got periods between treatments or you're feeling under pressure, feeling in the hospital environment, you know, if you are fortunate enough to have a Maggie's Centre attached to your hospital, I know there's one at Charing Cross near Professor Sikora, do go and use those. They also have really good online and remote support. On those resources, obviously all the ones that you would expect, they're just, as I was talking about managing anxiety and breathing exercises, they are on that NHS website there. Keep talking, keep looking after yourself and taking it day by day. There will be days where we do feel very frightened, either of a cancer, of COVID, of the effect on our finances, whatever it is, but there is help out there. Please keep talking and keep well.
Thank you, Michaela. Well, I would like to extend a huge thanks to all three of our presenters today. I found that to be a really informative discussion with lots of experience from different perspectives, all of which is extremely valuable. So thank you for contributing to the discussion today. I'd also like to say thank you for everybody that's tuned into the webinar to listen. We hope that you found it useful. And take care, everybody. Thanks for your time.
Thank you.